Welcome, everyone. We just want to give it a few minutes to let others join us. We're going to get started in just a few minutes. Thank you. Welcome, everyone, to Debbie's Dream Foundation Curing Stomach Cancers, Understanding Barriers to Health webinar. Before we begin, we'd like to acknowledge our generous health equity sponsors, Arcus Biosciences, Astellas, Bristol Myers Squibb, Genentech, Merck, and Taiho Oncology for making programs like today possible. Next slide, please. At this time, I'd like to introduce today's speakers. Today we have Elkin Alfred. She's Director of Equity and Culture at the Denver Zoo, Health Equity Chair at Debbie's Dream Foundation, and she's also a longtime board member at Debbie's Dream Foundation. Welcome, Elkin. We also would like to introduce Aisha McDonald. She is Director of Training Initiatives and a certified trauma expert at the United Way of Broward County. Before we begin, I'd like to invite everyone to drop any comments that you may have in the comment section if you're watching from Facebook Live. There will also be an interactive component, so your engagement is welcomed and appreciated. Thank you so much, and I'll turn it over now to you ladies.
Thank you so much. Super excited to be with you all again. Again, I'm Elkin Alfred. I'm currently residing in Denver, but I am from South Florida, Haitian girl born and raised in South Florida. I like to share that. And I'm a long-term proud member of DDF. And so it is always a pleasure and honor to be able to speak on health equity.
And I would just like to say welcome to everybody on behalf of DDF, on behalf of United Way of Broward County, where I work as the Director of Training Initiatives, and I oversee our health equity program. We're always grateful to have everyone here today, and we always want to acknowledge the Native people on whose ancestral homelands we gather, as well as the diverse and vibrant Native communities who make their home here and in Denver, Colorado today. Thank you all so much for joining us, and we're going to jump right into it. And so to begin, we just want to really just capture when we talk about access to healthcare, what we really mean. And in considering access to healthcare, we need to understand that a person's ability to really access appropriate and relevant healthcare is going to have an impact on what their overall health will be. And for a lot of individuals, they lack that access. And when you lack that access, that leads to higher morbidity rates, higher mortality rates, higher rates of chronic illnesses not being treated appropriately. And so when we talk about access to healthcare, we're not just talking from an individual level, but we're talking from a system-wide level. We need to understand what are the barriers and how we can overcome that so individuals can access quality and relevant care and treatment that they need. And so, and some of the key barriers that we'll talk about are going to be very much related to our social determinants of health, which Elkin is going to really address later on in the session. But to just really give some highlights as to what do some of those barriers look like. Well, having a shortage of healthcare professionals is one barrier for individuals being able to seek the appropriate help, especially a shortage of diversity in the field for individuals to be able to connect with clinicians, professionals, healthcare workers who look like them and can relate to them culturally as well as ethnically. Transportation access, lack of health insurance, and not just lack of health insurance, but also even for some of the individuals who may have health insurance, having financial constraints in being able to afford healthcare and the relevant treatment that they may need. And of course, language barriers. We live in a country that has such a diversity in cultures that's also related to diversity in language. And there may be communication conflict in how things are being communicated to individuals who may not have English as their first language. And even for some of us who have English as our first language, the use of jargon may be conflicting in how we can better understand our healthcare needs. And so we'll dive into these during the segment on social determinants of health, but these are just some of the key highlights. So as we're considering barriers to healthcare, it's important that we're really paying attention to how some of the other issues and barriers show up that limits people's access to care. So when we talk about stigma, and stigma is those negative preconceptions and notions that individuals hold that sometimes keep individuals limited in the help that they can get. And we know when it comes to the healthcare field, stigma is pretty dominant and relevant in how individuals are able to get diagnosed, how they're able to get treatment, and what will determine whether or not they have successful health outcomes. A lot of the stigmas that are related to health condition keep people living with those conditions and not getting the appropriate care they need. And a lot of it really conflicts for individuals to even want to seek help in the first place because they are pretty much afraid of what the reactions they'll get will be from the professionals that they're dealing with or how they'll be treated. And when we think about stigma and how it really impacts long-term health treatment, we need to understand some of the barriers that it poses in people wanting to seek services in the first place, especially when that stigma is related to living with certain diseases and or certain health conditions. So I'll use two examples of stigma in the health system that have really just been pervasive for a number of years. So one is obesity. There's a lot of health related stigma towards obesity to the point that there is currently talk in the field about changing the language from even using the diagnosis as obesity and changing the diagnosis to a different one because of the stigma that that word holds. We know that there are quite a significant amount of fat phobia that really lives in our society, and that impacts how people can get the help that they need and how some of their needs are addressed. Because for a lot of individuals, going to the doctor and making those medical complaints about feeling certain types of pain or having certain medical complications sometimes always reroutes back to it being related to their weight rather than really paying attention to the true concerns that the individuals have. And so for a lot of people, because of the stigma that they hold related to obesity, a lot of individuals may not get the appropriate care that they need because the focus is on their weight instead of other related issues. And so that's one of the examples of stigma that has been very pervasive in healthcare for a number of years, with some individuals also being even fearful of going to their medical providers when they're experiencing certain things because they're afraid that it's going to come back to their body image instead of really delving into the true issue. Another long time stigmatizing condition that has been pervasive in our society as well as in the medical field is related to HIV and AIDS. So prior to the 1980s, the acronym was actually GLB, was gay, lesbians, and bisexuals. That has since changed because with awareness, we've expanded it. It is now LGBTQIA2SP plus. There's more letters in that. But one of the significant things that they did after the 1980s was they put the L at the forefront for very specific reasons. And one of those reasons was because during the height of the AIDS epidemic, it was the L's of that community, the lesbian sisters and comrades of so many individuals that were the ones that came in to help provide the necessary care for individuals who had been diagnosed and living with HIV and AIDS. Because of the stigma that was related to that medical condition at the time, there is a plethora of stories and lived experiences of individuals who shared that even the medical professionals in a lot of facilities refused to give appropriate treatment and care to the individuals who were living with AIDS. There is a lot of recollection of medical professionals, nurses, and caretakers refusing to go into the rooms, refusing to bring them their meals, refusing to clean them. And it was the L's of the LGBTQ community who went into these facilities and fed them, took care of them, really cater to their hygiene needs, and so forth, because it was so stigmatized as a condition for so many years. And so the stigma in healthcare limits people's access. It limits people's access to not only just the medical care that they need, but the human care that they need, of feeling like human beings who, despite their illnesses, still want to be cared for, still want to be loved, still want to be felt compassion towards. And so we really need to broaden our ideas when it comes to stigma of how severely negatively impactful it can be for a lot of individuals that are living with diseases and health conditions that are so regularly stigmatized in our community. And times have changed, but we still have some change to continue to do and to continue to grow into. Another one of the significant barriers to healthcare is also the mistrust that a lot of communities have in the medical field towards research as well as just medicine in general. A lot of the mistrust that has historically been in this field has resulted in a lot of worse outcomes for patients. And when we really think about the historical precedents of where this mistrust is rooted, it's easy to understand why, right? It's easy to really take a step back and look at throughout history, there has been groups that have been marginalized based on their race and their ethnicity that have had experiences of discrimination through medical research and healthcare. And this has caused a lot of individuals to intergenerationally pass down that mistrust and fear as it was rooted in throughout the system because of how they've been treated and affected by institutionalized systems. So some examples of these are Native tribes and Alaskan Natives, especially, who were taken from their reservations and taken from their communities, especially as children, and put in boarding houses and boarding schools, and then used for experimentation in a plethora of medical practices, and how a lot of those individuals, this resulted in alienation from their culture, most of all, alienation from, their tribal just history and heritages, but also for some of them, it resulted in fatalities and long-term medical issues. And so for those indigenous communities and those tribal members, that mistrust is rooted in the fact that this had been done to them. Their children were taken from them. And so the fear that had spread in those communities keeps a lot of individuals mistrustful of the healthcare system and governmental system in ways because of what they experienced. There's also the Tuskegee trials that happened over the space of 40 years, It started in 1932 and continued until 1972. And for those of you who are unfamiliar with the Tuskegee trials, this was a study that was done on syphilis victims who were mostly Black men in the United States. And a lot of these individuals thought that they were being treated for healthcare issues when in truth and in fact, they were actually being experimented on to see what practices could work, what treatment could work, what medicine could work, and what couldn't, but also to see what the progression of syphilis looked like when it went untreated. And so these are the individuals who thought they were receiving care and actually had not. And as a result of this, over 100 individuals that were a part of this study died, not just the men that were experimented on, but also subsequently their wives who contracted the diseases from them and their children to who they passed this disease on. And that was a space of 40 years of studies done on a whole group of people. And so the mistrust for that group, for that ethnic population is rooted on the fact that instead of making us better, you use the system to make us worse, right? For a lot of Latino and Hispanic women, the mistrust has come from a long history of forced sterilizations. In fact, there were actually cases of Puerto Rican women who were sterilized without their consent as well as without their knowledge. And so this was done to prevent them from reproducing because it was just thought that this would be better for us as a community if we stopped these individuals. And so for a lot of people, this was done without them even knowing that it had been done to them. And so their mistrust is rooted in things have been done to us that we were not even told about, that we were not a part of, things done to our bodies that we did not even agree with and did not consent to. And then, of course, there's the story of Henrietta Lacks. And Henrietta Lacks has been very prevalent in the news recently because her family has just won the rights to be compensated for how her cells were used after her death. And this has been a long time story of how her body was used for medical experiments, even after she had passed away. Her cells were used in a plethora of different types of experimentation on making vaccines, on examining what could work for certain communities and what couldn't. And so when we look at these, and these are just 4 examples of a long history of experimentation that were done to Black, Indigenous people of color, and how that has been rooted in doing things to entire groups of people without consent, without fully informing them, without even letting them or their family knows what was happening. And so when we look at the racial and ethnic implications of this and how that emerged in our institutionalized systems in the healthcare system, it really speaks to the fact that the mistrust didn't just come out of nowhere. The mistrust is not unwarranted and the mistrust isn't irrelevant. And so how can we really take a step back and understand that how that fear and mistrust at its root has now caused limitation in people being able to access the care that they need when they need it. Another significant barrier to care in the medical field is the implicit and explicit bias that are oftentimes showed to marginalized groups of people, right? And so a lot of the times, and we know what explicit bias is, right? Explicit bias is obvious. It is the overt actions and behaviors that are taken. But the implicit bias sometimes goes a little bit unrecognized, if not properly checked. And as my counterpart Elkin always says, every time we do an implicit bias training, if you have a brain, you have a bias. As human beings, we hold biases to be real and true for us based on our experiences, how we are taught, or even just societal expectations. However, it becomes even more limiting to people getting the care that they need in the healthcare field when it is the providers that are holding these biases, especially against racial and ethnic minorities, against individuals with disabilities, and against the LGBTQ population in ways that don't allow them to get the appropriate help that they need. In fact, it was oftentimes believed that, well, if individuals have certain insurances or have attained a certain socioeconomic status, then they would be exempt from having to experience that bias. And studies have shown us actually no. Even with having insurance, even with having higher levels of socioeconomic status, a lot of individuals who are in these marginalized groups oftentimes receive lower quality of healthcare than their white counterparts do. And we know that when we consider the bias in the medical field, it is not individual bias. Sometimes it's learned bias. It's individuals and professionals who have learned that, well, Black women don't feel pain at the rates that white women feel pain, so we don't have to prescribe pain medication to them. And so that limits their ability to get the appropriate help that they need. It can sometimes be as simplistic as not recognizing pronouns or preferred names that individuals go by. And so that limits the ways that these individuals are able to navigate the healthcare system because there's such a complex system of discrimination, of biases that can cause these inequities in healthcare because the lack of access isn't there. Or for a lot of individuals that may be more prone to wanting to go to see professionals that they can racially or ethnically relate to, well, there's limitations in that because there may be a lack of diversity in the field in those communities that makes them unable to access individuals that they have shared experiences with or shared backgrounds with. And so when we consider this, we also have to keep in mind the limitations that legislation puts on certain individuals being able to access care as well. And so if I just don't feel as if my voice is going to be heard, if I don't feel like I'm going to be understood, if I don't feel as if I'm going to be paid attention to when I make certain medical complaints, or if I'm treated with either these negative, explicit, or implicit behaviors by the person who's there to provide me this care, I may not go back. I may not be prone to seeking out help again. And due to these biases, it causes certain disparities for a lot of individuals' access to care. And so when these inequities are prevalent, we know that individuals may not have great health outcomes, especially for these particular type of illnesses and screenings, right? For cancer screenings and treatment, there are huge racial disparities. For Parkinson's disease and dementia and other neurological issues, even how individuals access care at their end of life and how they're treated and how they're listened to have racial disparities. For cardiovascular diseases and treatment, for pain management, for the care of individuals that are living with HIV and or AIDS, and then very, very importantly, for the neonatal care, for the individuals even at birth are experiencing racial disparities in their access to healthcare, as well as for the maternal care. And a lot of individuals, because of the racial bias in the healthcare system, may not have access to testing, or they may live in high density communities that make them more exposed to things, especially being more exposed to pollution. A lot of racial and ethnic marginalized communities are more likely to have pre-existing conditions that they may not even have recognized or known about because of the limitations in their access to care. And a lot of racial and ethnic marginalized communities are more likely to be essential workers, which then leaves them more exposed to certain illnesses and diseases. And so we're going to delve into social determinants of health, and I'm going to turn that over to Elkin.
Thank you, Aisha. That was very helpful to set the stage for the next couple of slides. So I want to be clear what social determinants of health are, and they're defined by the CDC. Social determinants of health are the conditions in which environments where people are born, live, learn, work, and play, worship affect a wide range of issues. So for a very long time, we often made assumptions about someone's health based on their own individual actions. And so what social determinants of health asked us to do is to look at our systems around us that impact our health. And so we're not looking at just individual behaviors, right? We're not just looking at, am I exercising? Am I eating healthy food? This is looking at what are the systems in play that impact my ability to obtain optimal health. You can go to the next slide. So education. So the first social determinant of health that we're going to discuss is education, access, and quality. And so this particular domain and social determinants of health really addresses our health literacy. So what is our education system, or the access that we have in our education programming and learning? Does it equip us with the knowledge on what does it take to be healthy? Does our education system include knowledge around what are healthy eating habits, right? How much fruits and vegetables should we have? Our water content, and do we also have the language that we can then use in our interactions with our healthcare providers, right? So if I am someone maybe that English, like my parents, English is not their first language, they're going in to seek medical care, is the clinician or the provider, are they taking into consideration the verbiage, the language that they're using? Is it accessible? So also thinking about poverty, right? We know that poverty impacts, if you live in a neighborhood that is impoverished, we know that it also impacts the funding to your school, right? That's the system that we have created and designed in this country, that taxes then go back into your school system. So if there's a low tax base in your community, how does that impact the overall education system in that particular community? You can go to the next slide. So access is also around insurance. I am very blessed. I work for a company where I have really good benefits. So I have access to high quality insurance where there's low deductible payments for me. And so it's not only do you have insurance, but also is the insurance affordable? Do you have insurance and you're required to pay $50 every visit? If I am someone who's on a really limited income, I may not be able to pay the $50 copay every time I go to the primary care physician. And so that's going to impact my access to continuous care, even if I have a illness or chronic illness that requires multiple visits. So quality is, who are the providers, right? I'm also thinking about, are the times flexible with my schedule, right? So I'm an individual who my job is very flexible. I'm able to leave during the middle of the workday and come back, but I'm thinking about our essential staff who's flexible, whose work life is not that flexible, meaning they aren't able to take off. They don't have the PTO, they don't have the sick time to be able to take off to go see their primary care physician. And do I have access in proximity, right? And so I'm thinking about our individuals who live in rural communities. Their nearest clinic may be an hour away. And so that distance is also going to prohibit them from being able to access quality healthcare. You can go to the next slide, Aisha. Right, so this is something that is so important to me, and it's something that I realized that I probably lacked growing up. And now that I'm in Denver, I realize what a privilege it is to be in a community that is designed with your health in mind. And when I say that, do we have access? Do you have access to outdoor spaces that promote wellness and physical activity? Are there bike lanes in your community? What is the transportation? Do I have access to reliable transportation to get me to and from a medical appointment? And so we know that racial and ethnic minorities are more likely to live in communities that don't have access to those things. We know that access to nature not only is good for promoting physical play, but it's also good to promoting clean air. And so we have to think about that when we're designing communities. And so I like to pause on this for a little bit. And if you are listening or you're maybe watching this recording later on, to think about your childhood and think about whether or not you had access. How close was the park? Was it in walking distance, or did you have to drive? Was it a special trip that your parents or your guardians had to make? And all of those things we know play a role in our ability to achieve optimal health. And when we're talking about health in this context, I want to make sure that everyone understands we're talking about physical health, but also mental health. And so in social determinants of health, I want to make sure that we're thinking about this holistically because they impact each other. Aisha, I feel like you wanted to say something, that you wanted to jump in, so I'm going to pause here.
So I do, because this one, you when you said consider, like several things like flashed through my mind, right? Because I started comparing, like as soon as you said consider, I started comparing my childhood experiences with my built neighborhood and my children's current childhood experience. And my sister likes to jokingly call my kids suburban kids. And I like, no, they're not suburban kids. They're, I'm raising them to be from the streets like I was. But I didn't have access to green space growing up. And I didn't realize how detrimental that was to like just overall health, mental health, everything. I lived in a community that had high rates of violence and other safety and health risks. And I can remember like, yeah, there was one park, but it was concrete. Like there was no grass, the trees were kind of bare. And I remember there was like one particular day where I was home with my children, and one of the professionals who work with my kid came, and we were like, let's take them out to a park. And we drove to a nearby park that is 3 blocks away. And there was an event going on. And so the professional was just like, well, I guess no park today. And I was like, no, 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 we can just go one more block over and go to the other park. And we drove over to that park, and then she she was shocked because she was like, wait, how many parks are there? And so I pulled up, and in about a 2-mile radius, we have about 5 to 6 parks, nature preserves, walk-in parks, things that go out into the lakes that have alligators, of course. But there was so much access to things that I never really considered how impactful that is going to be for my children to grow up in this type of living experience that I lacked growing up. And as you were talking, as you said, like consider, I instantly made like a comparative of, whoa, this is impactful. And this does have long-term effects on what we're exposed to and what harms our health and helps our health.
Yeah, thank you for sharing that. I think it's important for us to think about our own experiences and sort of and then look at social determinants of health and look at like how that impacted our own upbringing. I like to share, I think it's Boston University or Boston University, I believe, or medical center. What I love that they're doing around social determinants of health, and I'm thinking specifically around built neighborhood, they're also including some training around advocacy for their patients, right? So example, pollution impacts our health. And we know that for Black and Brown kids, they oftentimes live in communities that have high pollution, which impacts their asthma rates. And so what does it look like for integration of not only health literacy, but also advocacy literacy, so then these individuals can go back to their local government and be mindful and stress the importance of, if you're going to have a company here, how can we make sure that they're minimizing their impact in the environment, that we have access to clean water, and we have access to clean air, because those are all impact our ability to have optimal health. You can go to the next slide. So social and community context, this is so important. And Aisha talked about it a little bit, about the importance of having clinicians, providers who have similar lived experiences that can identify with the patients, whether it's using colloquial terms in your assessment with the patient, whether it's having bilingual or translated health material, all of those things matter. And we know that community, having a sense of community and friends. I think Harvard has this study. It's the longest human study that they've been that exists, and they looked at what are their primary indicators for a full and happy life. And the thing that remains consistent across this study, across this multiple generation, is access to community. And so I read this book called The Blue Zone years ago. I'm not sure if you haven't read it, it's a really good book. And it looks at communities where centenarians exist. So centenarians are people who live to be 100 and plus. And yes, what you eat, physical activity is really important, but also what they realized that all these communities had in common, no matter the cultural context of which they lived, was access to community consistently, right? Having people that you can relate to. And one group, there was a group of older women who met every Wednesday. And that community, and they met every Wednesday to gossip. It was something very simple, but that social bond had an impact on their longevity of their life. And so how are we designing our communities in that way? I also want to think about, is the community safe, right? Safe from violence. Does the community do you have access to food? So oftentimes we talk healthy food. We talk about food deserts. Many Americans still live in food deserts, meaning they live in a community where they don't have access to fresh fruits and vegetables. And so how can we design communities where they have access to those things instead of just them having to go to the corner store to pick up food that's filled with products that are not healthy for us? And so all of those things have a negative impact on our health. And so I believe this is I think this is the last slide on the social determinants of health. Oh, perfect, thank you. So economic stability. I think especially now we're having this conversation about inflation and the impact. And so your $5 doesn't go as far. So this is impacting our ability to secure safe and decent housing, which then has an impact on our overall health, because now we're stressed, right? And we know that when we have higher rates of stress, it impacts our immune system, right? It sort of turns on the switch that where our bodies are more inflamed and we have inflammation, and we know that impacts our ability to obtain optimal health. I also want to think about people who have disabilities. Do they have access? Are our health systems accessible to them? Do we have providers who understand the impact of disabilities or conditions such as arthritis? What are the impact that it has on your overall ability to achieve optimal health? And so we need to have a comprehensive conversation around what will it take to increase economic stability. And can it be economic literacy, right? Around what can we do to promote savings? What can we do to promote individuals contributing to their retirement? And then what are our businesses doing to support economic stability, right? And so this is comprehensive. This is not just an individual, am I making the right decisions? I can be doing the best that I can, but it's not enough in this economic state that we're in right now. So thinking of that, because our medicine is expensive. And I'm thinking of friends who have their monthly medication is $400 or $500 a month. And so for a family, right, that's living at minimum wage, they may have to make the choice to skip their meds for that month or two because they have to pay other bills. So we're thinking about medication adherence. The ability to be medication adherent is going to be compromised based on our economic stability.
I have a example of that with a client that I once had, a youth client who was brought into our hospital. And one of the discoveries that we made, what the client was there for mental health related issues. And then we discovered that she hadn't been adhering to her diabetes medication. And I remember, ask the question when we first started asking seemed very related to the parents just being unable to give her the medication as needed. And I recall one of the professionals who worked in the facility jumping to the conclusion that we're mandated reporters and we would have to report this as a child abuse case for neglect of medication. And I was like, whoa, whoa, whoa. And this was the patient at the time was a Black young female patient. And I was like, whoa, 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 let me go talk as a Black female. Let me go talk to this Black female before we call in. And there wasn't any other evidence that it needed to be a mandatory report at the time. And I didn't want to jump to that and then cause this distress upon our whole family. But they were like, well, no, it meets all the criteria. This individual has an illness. They're not getting the meds appropriately. The parents are neglecting. And that was just the justification. And I sat and I spoke with the patients. And when I questioned, they did not have a refrigerator and they could not pay their electric bill. Those were the two issues that were conflicting. And the medication that she had at the time had to be kept refrigerated. And that was it. She was like, well, even if we did have a fridge, which we don't have electricity right now. So, and I can't take the medication if it's not that. And I remember going back to the team and having a discussion where this is not due to neglect. This is due to poverty. Like, now you're going to bring in a whole child investigation case on a family because they're poor, when we really need to be examining what are some alternative medication that she could probably get, or what were some resources we could connect them to get their light turned back on. Like, as simple as that. Like, how can we get their light turned back on? And is there anywhere where they can get a cheap fridge? But it had become this whole issue of child neglect and abuse, when it was really because they were living in poverty and did not have the economic stability to keep her medication refrigerated. That was it.
Yeah, and that is a great segue to talking about social determinants of health forces us to look at our system through an integrated lens, right? Not look at just the individual, but even look at how can our healthcare system partner with our social services system, partner with transportation system, partner with our local government, state government, federal government in a way that's really comprehensive to mitigate the system that then impact our ability to have optimal health. And so what does it look like when your social services department in your hospital system is working with the housing system, right, outside of the hospital system? What does it look like with, is there an opportunity to be transformative where healthcare professionals are going into health classrooms, right, and providing a baseline to promote health literacy, right? So then we can make better decisions as individuals. And what does it look like partnering with groups, right? Maybe there is a Hispanic serving organization and ensuring that the medical literature or the healthcare literature is translated in a way that's going to be received. And so these are things how, as individuals, as leaders in our organizations, as systems, it's going to really require us to work more intentionally and more collaboratively in order for us to really have a country and nation where we are healthy and thriving. And so I just wanted to pause there. What does that look like? What does that look like if we're more intentionally working collaboratively across systems to address food insecurity, housing, neighborhood safety, social support, um, inclusive, um, an inclusive framework, right? That also looks at us not just through one identity lens, but through through the lens of intersectionality, right? Because we know we're not just one thing. So looking at our disability, our veteran status, what is that? And you know, Aisha and I trained police officers for a very long time, and one of the things that uh, I also encourage police officers to do is they work high stress jobs. And I know because of that, their bodies are activated in a way that my body may not be activated. Um, and so it's important for them to let their healthcare professionals know that, hey, I'm a police officer. And because I'm a police officer, I know I'm more likely to die of a heart attack. Uh, and so these are all things that I think is important for us to think about. As we design systems to help create awareness, quality care for healthcare.
So that segues really, really well into my solutions, Elkin, because you already brought up several of them. As we're looking at these barriers, it's so important that we're also exploring what the solutions are. And Elkin gave some system-wide solutions that we need to really reflect on from individual basis and institutionalized basis as to how we can really combat these barriers and really provide people with that access to care and that is going to be instrumental to their long-term health. And so there are some system-wide solutions that have been developed that can be sincerely impactful in people getting the appropriate health. There's telehealth services, and we've seen over the past 3 years a real growth and expansion of telehealth that has been able to really provide access to care for individuals that have limitations in being able to physically go into facility or who may not have had the proximity to health systems. I know working throughout the state of Florida, I sometimes go into more rural communities, and I recall asking one particular area I was in about a local hospital, and they're like, "Oh, well, the hospital is," and they named it. And I knew geographically that that hospital was 3 towns over and about an hour away. And I was like, "Wait, what hospital do you have here? Like, what is your access to care here?" And they named the hospital again. And I was like, "But if something happens, how do you get there?" You know, if emergency services has to drive an hour to come get you and drive an hour back. And so even just preventative care, being able to access that through telehealth is instrumental in people being able to really gain the services that they need and really be able to have their needs addressed. There's also mobile clinics where individuals are brought to the facilities that they are going, that facilities are brought to the communities that have the limitations in access. And so those mobile communities and the mobile clinics go into these communities, go into these areas that they know don't necessarily have those standalone buildings, and then they're able to really provide the care there. We have one such type of mobile clinic here that not only just provides medical access and care, but also has a syringe exchange program for individuals that may have substance use issues and concerns. But it's not just based on, hey, give us your syringes and we'll give you a new one. It's also connecting them to the necessary health care that they may have as a result of their long-term issues. And so those mobile clinics are a really good way of really strengthening that access to care. For individuals that may have insurance or no insurance, as well as financial constraints, student-run clinics are a really good way of really impacting those because they're able to provide the individuals with professionals and paraprofessionals who are in the field or working towards being in the field at very minimal costs. And these individuals are, of course, supervised and guided by long-term professionals and more experienced individuals, but they still give care. You have student-run clinics for dental services, for medical services, even for eye care services. Student-run clinics that are connected to universities where this is what they're learning, giving them experience of working with diverse communities, but giving those diverse communities the experience of, well, hey, I can pay a sliding scale fee to still gain access to medical intervention. And then there's the co-clinics that have been popping up all over the place. We see these as the minute clinics. They're sometimes attached to Walgreens, to CVS. There's Beeper MD, which is a clinic that really popped up throughout the pandemic that first was only offering COVID testing, but now goes on to offer even more deeper medical services. And so looking at these system-wide solutions allows us to strengthen that access to how can we get, if the people can't come to us, how can we get it to them? You know, and if the people can't afford to come to us, how can we really lower the costs in order for them to get something? And then some other solutions, especially when we're talking about the mistrust and the bias in the field overall. This is how we tackle it from a system-wide lens, but also an individual basis, right? First of all, trust people, trust the patients. A patient comes to you with a medical complaint. A patient comes to you and says, I've been in pain. Trust that that person is in pain and really listen to them instead of making assumptions about what you think might be the real issue or the problem, right? And so trust in individuals to be able to really tell you what their concerns are. And of course, we know I am very, very guilty of it. A lot of us are WebMD kings and queens, where we go online and we research and we go and we know what's wrong with us and we don't want the medical professionals to tell us otherwise, right? But some of that may be real and true issues. I remember going and complaining to doctors about uterine pain for years and years and years. I was having significant uterine pain and being told over and over again, oh, you're just, overreacting. You're just being dramatic. I remember even asking if I could get tested for endometriosis. Please, I web on WebMD, and I saw I have all these symptoms. Can you give me this test? And being told to stop going on the internet and trying to do our jobs, only to long-term be diagnosed with precancer cells and polycystic ovarian syndrome. That could have been recognized early on if I had just been listened to. And so trust in individuals to know what's going on with their bodies is impactful. Enhancing the cultural competency, enhancing the cultural sensitivity, the cultural awareness, so that we can have more diversity and inclusivity, especially not just in patient professional relationships, but also in the workforce overall. Really taking a step back and looking at what are the professionals, what do they look like, and how can we expand that to show a more diverse workforce so that individuals are more inclined to come because they feel as if there's a relatability in the people that are working with them. How can we build trust? How can we really mitigate the mistrust that historically has happened through research and experimentation and really build back the trust for historically oppressed communities that have been taken advantage of? How can we prioritize that relationship building? How are we building rapport? And I know that there's limitations in the time that is spent in these offices, what insurance will pay for, but how can we use that limited time to really prioritize the relationship in a way that will continue to build that trust, that will enhance that relationship, that will allow for people to feel safe, brave, and listened to? And of course, making sure that when we're faced with patients that may have some certain core beliefs, even though we want to get our points across, even though we want to get them the best services and care that they need, we're not challenging those beliefs in a way that will leave patients feeling overwhelmed, leave them feeling spoken down to and condescended, or leave them feeling as if they were not heard. And so how can we make sure that we're not challenging in ways that will cause conflict, but still providing people with information that is going to give them the relevant care? How can we meet people where they're at? And for some individuals, it may be trying to explore my internal biases that I hold. I've been in doctors' offices where I've seen signs on the walls of, we will not, a doctor will not see you if you're dressed a certain type of way. Do not come in here with these type of clothing. Do not wear your bonnets in this office. And I'm like, well, if we're already, before they're even seen, telling individuals that we're judging them based on their appearance, are they likely to want to come into that space? Are they likely to come back? And for some individuals, how do I know that this isn't all they have to wear? I remember being young and going to certain churches that said, come as you are. And so I would wear jeans and they'd be like, okay, and not like that. Don't come like that. I didn't go back to those churches. I didn't go back to those establishments. Can't tell me to come as I am and then don't allow me to come as I am, right? And so how are we making sure that we're creating a space that allows people to feel included? And considering the culture of your own team, not just diversity wise, but also what does the morale look like for the people working there? I've walked into offices and seen the faces on people. I remember while I was pregnant, talking to an individual in an office that I was just trying out. And I asked the person, like, would you come here if you were pregnant? And they were like, oh, hell no. If you don't even trust the professionals you work with to help you when you're in the same situation, how then do I feel comfortable coming here? And so really consider, what is the morale of your organization? What does your team look like? How are you building trust internally in order to show that trust to the individuals that you're working with? And how can we make sure that we are preventing and mitigating burnout? For so many of us who work in helping professionals and are these frontline service providers, we are taking on a lot of the impact of the trauma and the stress that so many individuals come to us with. It's contagious. We feed off them. And so how are we taking care of ourselves and our teams? Elkin.
Yeah, I just wanted, so that's an excellent point that you brought up. And so if you have not looked at the CDC's, not the CDC, but the Surgeon General's report on workplace well-being, if you are listening and you're a hospital administrator, I'm going to encourage you to look at the report. It provides you really tangible tools, strategies that your institution can look at incorporating, because your ability to have a workplace, and I'm referring to individuals who are tasked with building healthcare facilities or those who are providing healthcare. The healthcare and the well-being of your staff is critical to the healthcare and well-being of the patients that you see. And so I'm going to encourage you to look at it. It's a workplace for well-being for workplace by the Surgeon General. I think he did, it was October of 2021. And so it's a phenomenal report that you can look at to help your team sort of do some internal work on what they can do to ensure the well-being of your providers.
Thank you for bringing that up. And I think that's definitely something that outside of just this field overall, everybody should be exploring and looking at, because it's so important that we're treating the people in the workforce with respect and dignity, and understanding that they're at further risk from developing their own issues and concerns too. So how can we make sure that we're working to prevent that? So this is the research and some of the information that was shared today. I do want to say a special thank you to Debbie's Dream Foundation for having us as usual. Any space that somebody can allow me to talk about inequities, I am there. And I usually am bringing Elkin along if she wasn't the one who invited me in the first place. So we do want to say thank you for just allowing us to have this session and this really meaningful conversation on how we can really address and understand these barriers. I'm going to open it up to questions. If there are any questions, any concerns, any statements, any highlights, any favorite parts, I will turn it to you, Brittany.
Thank you so much. That was such an informative session. It really got my gears going, and I'm thinking about all of the ways that I play a role in my own healthcare. We don't have any questions, but I have a question. What are some ways that no matter what socioeconomic background, cultural background someone comes from, what are some ways that we can advocate for ourselves to help eliminate some of the biases that you ladies talked about today? I know health equity is more of an aspiration, right? Because of things that have been done systemically, or just the structure of things systemically. But what are some of the ways that we can advocate for ourselves?
Ooh, that's a great question. I think when you meet your provider, I think it's important to research your provider if you have the ability to and access to do that. In your first meeting, to be clear that this is a co-relationship, meaning being clear that you're invested in your healthcare. I would also say if there is a word that is used that you do not understand, or a test that is being asked that you take part in, that you ask questions. Why is this? And to continue to say, hey, what is the goal of you sending me this to this provider? I think those are simple ways to establish in the very beginning that you want to be seen as someone who is taking their healthcare seriously. And then also being honest about what you have access to and what you don't have access to. If you work at a place that makes it difficult for you to take off time in the middle of the day, ask, hey, are there any other alternatives for us meeting? Can we do telehealth? So I would say those are simple things that you can do to advocate for yourself. I also think advocacy is also outside of the healthcare institution. Advocacy is also around your local government. If they're having conversations around redesigning spaces, is it inclusive of green spaces, and will you have access to that? Is it inclusive of having access to fresh fruits and vegetables in your neighborhood? Are those the type of businesses that your local government are trying to solicit into your neighborhood, or are they only giving business licenses to the liquor store or the corner store that's not providing you fruits and vegetables? And so I would say advocacy is not only inside of the healthcare, but advocacy is also outside of the hospital system. I don't know if you want to add anything, Aisha.
I think the one thing that I would add is, and I've had several experiences with inequities based on, numerous of my identities when it comes to healthcare, both for my family members as well as for myself. And I think for me, understanding that healthcare professionals are experts in their field, yes, but they're not the only authority that you need to listen to and adhere to. There has been several times where I have just taken their word for granted because you're the doctor, you should know, and then ignored my own body and my own like gut instinct that no, this feels like more. I feel like there's something wrong. I've gone back home and be like, well, the doctor said, and that's it. And I come from a culture that respects medical professionals as, the law. Like, this is the authority, this is what they said, take it as it is and keep it pumping. Only for that to result in like complications further on. So, and I say this when it's like my own feel, and people are like, oh, well, I had a bad experience. And I'm like, well, shop around, find somebody else you can better relate to. So I say this of all fields. Like, if you do not feel comfortable, if you do not feel like you're being listened to and understood, shop around, find somebody else. And it's not always that easy, especially with limitations in insurance or financial constraints. But if you don't feel as if this person is taking you seriously, I had one particular negative experience through a telehealth appointment that I made once. And it was like just my insurance company had a telehealth system. And I know my body well enough to know when I have a sinus infection. I have sinusitis, asthma, and bronchitis. I know all the symptoms. I know every time it happens, I know exactly what's gonna happen next. Oh, my face is hurting me. Okay, tomorrow I can't breathe. Like, and all of that was happening. And I had a really negative experience with that particular doctor who was proposing that it was related to issues that was based on propaganda and conspiracy theories and not actually medical facts. And it was really disconcerting to hear like somebody who you expected to be the authority telling you Twitter conspiracy theories. I was like, sir, even the people on Twitter don't believe this, and you're telling me this. And in light of Elkin's statement about advocating for yourself, not only did I not listen to him, and I actually called the pharmacist when the medication was sent to ask for their pharmaceutical advice, and the pharmacist was like, "Oh, absolutely not. This medication that you were prescribed has no relation to what your medical complaints are. Call a different doctor." And I was like, "Thank you, pharmacist," instead of just picking it up and taking it. But then I took it a step further. I contacted the insurance company to let them know that I had been recommended this by a medical professional I found through their website. They were very disturbed at what had been said and how it had been told. And they took it even further as to filing a formal complaint against this professional because they were fearful of how many individuals were probably just blindly believing in what he said and not getting the adequate care that they need. So sometimes it's just making sure that if you don't feel comfortable with it and you research it and that's not the advice that's being given, find a different route. And also some professionals just suck, like for lack of a better word. They're human, they're flawed themselves, and we have to also give compassion and grace to that, but also make sure that things are being done in our best interests. So, and also for anybody who's interested in learning more about health equity, we do have a free training program. If you are a professional, it offers CEUs for all ranges of medical providers. And you can find out more about that at healthequityprogram.org, healthequityprogram.org. And that gives a lot more in-depth insights into all the barriers to health that we discussed today.
Wow, thank you so much for both those explanations. You actually took the next question out of my mouth and answered it so well. Thank you, ladies, both for taking time out of your busy schedules to help educate our community. We appreciate you always. Thank you all for tuning in today, for taking time out of your busy schedules to educate yourselves on this topic of health equity for all. And we'd also like to thank our health equity sponsors, once again, Arcus, Astellas, Bristol Myers Squibb, Genentech, Merck, and Taiho Oncology for making programs like today possible. Thank you again. And until next time, you can always visit the website of Debbie's Dream Foundation to watch the replays of any of our programs and our educational webinars. So thank you again. Bye, ladies.